Hello everyone. Today we will go through gout quickly. Gout is defined as a form of crystal arthropathy or arthritis due to chronically high blood uric acid levels. Uric acid levels of more than 6.8 mg per deciliter or more than 450 micromole per liter is the most common cause of gout. It occurs mostly due to decreased renal excretion of uric acid or increased absorption. Uric acid accumulation forms urate crystals that are deposited in your joints and soft tissues, causing a hot, swollen, and painful joint. Gout may result in an acute gout flare, chronic arthritis, or tophaceous gout. In tophaceous gout, tophi lumps are formed that are basically subcutaneous deposits of uric acid, typically affecting the small joints and connective tissues of the hands, ears, and elbows. The distal interphalangeal joints are most affected in the hands. The non-modifiable risk factors for developing gout include genetics, that is, if someone has a positive family history of gout, they're more prone to develop gout in future, male gender, and increasing age. The modifiable risk factors include increasing weight, alcohol intake, high purine diet, for example, red meat and seafood, chronic kidney disease, cardiovascular disease, and certain medications like diuretics and cytotoxic drugs. The most common joint affected in gout is the base of big toe, metatarsophalangeal joint. Other than that, wrist, base of thumb, and big joints like knee and ankle can also be affected. Gout is basically a clinical diagnosis. However, it is important to rule out septic arthritis by aspiration of fluid from the joint. In gout, the aspirated fluid will show no bacterial growth, needle-shaped crystals, and these crystals will be negative birefringent, which means that you will see yellow crystals that are parallel to the polarized light and blue crystals that are perpendicular to the polarized light. Also, the composition of these crystals is monosodium urate. If you look at this X-ray of the affected big toe in gout, you can appreciate that the joint space is preserved. There are lytic lesions in the bones. These black dots, they're lytic lesions. Punched out erosions can be seen. Also, there is obvious soft tissue swelling of the joint. For treating the acute flare of gout, we have 4 options. First one is oral non-steroidal anti-inflammatory agents. If they are contraindicated, then oral steroids can be used. If both NSAIDs and steroids can't be used, then oral colchicine is useful. If none of the oral drugs work for you, then the next step would be intravenous glucocorticoids. Allopurinol should not be started during an acute attack of gout. However, if the patient is already taking it, then it should be continued. The choice of drug depends upon individual factors and contraindications of the drugs. For example, NSAIDs should be avoided in patients whose GFR is less than 60, who have hyperkalemia, or who have increased risk of upper GI bleeding, for example, duodenal or gastric ulcer, and if they are taking some anticoagulation. For patients who have uncontrolled diabetes mellitus, or they have a wound that has not yet healed, or we are suspecting any concurrent infection, in those we should not use oral glucocorticoids. Intra-articular glucocorticoids should be avoided if more than 2 joints are affected, there is lack of expertise, and there is suspected joint infection. Colchicine should be avoided if there is any history of allergy or severe adverse reaction to the drug, if there is combined renal and hepatic impairment, or the patient is using any drug that is a strong inhibitor of cytochrome P450 enzyme. The first-line treatment of chronic gout is allopurinol. It is a xanthine oxidase inhibitor. You initiate the allopurinol prophylaxis 2 weeks after the acute attack is settled. However, if the patient is already on allopurinol, then it can be continued during an acute attack. We start with a lower dose of 100 milligrams once a day, with the dose titrated every 2 weeks to aim for a serum uric acid level of less than 300 micromoles per liter. NSAID or colchicine cover should be used when starting allopurinol. Indications to start allopurinol include recurrent attacks. The British Society of Rheumatology recommend that in uncomplicated gout, uric acid lowering therapy should be started if a second attack or further attacks occur within 1 year. If there is tophi, renal disease, uric acid renal stones, or if the patient is on cytotoxics or diuretics, then allopurinol should also be indicated. In patients who have severe kidney disease, allopurinol is contraindicated. In that case, febuxostat, which is a non-purine selective inhibitor of xanthine oxidase, is an alternative to allopurinol. It is initiated at 40 milligrams daily and can be titrated to 80 milligrams daily for patients whose uric acid levels do not fall below 357 micromole per liter after 2 weeks of treatment. Uricose uric agents have also been approved for the treatment of chronic gout. These include probenecid, lesinurad, and benzbromaron. Probenecid can be used as monotherapy or in combination with allopurinol, but it requires multiple dosing. Also, it is ineffective in kidney disease. Lesinurad cannot be used as monotherapy. It is co-administered with allopurinol in patients who have not achieved target uric acid levels with allopurinol alone. And benzbromaron has been withdrawn because of fulminant hepatotoxicity. Other than pharmacological treatment of chronic gout, lifestyle changes can also reduce the risk of developing gout, which include losing weight if obese, staying hydrated, decrease alcohol intake and avoid during the acute attack, avoid purine-based food such as red meat, liver, kidneys, oily fish, and yeast products. Some studies suggest that cherries, moderate consumption of coffee, and vitamin C help reduce uric acid levels. These are some additional points for patients who have some other coexisting disease with gout. For example, patients with hypertension who become hyperuricemic or experience gout flares while they are being treated with thiazide diuretics may consider switching to another hypertensive medication such as losartan. Losartan is an angiotensin receptor blocker and it has modest uricose uric effect, and it may be an alternative to a diuretic. Also, low-dose aspirin may increase serum uric acid levels. However, it should be continued if required for cardiovascular prophylaxis because urate-lowering therapy with allopurinol reverses the risk of recurrent gout flare in aspirin-treated patients. Fenofibrate, which is a fibric acid derivative, is used for the treatment of hypertriglyceridemia, also has a modest uricose uric activity. That's it for today. If you found this video useful, then press the like button below, share it with your friends, and keep following me for more educational stuff. Take care. God bless you all.